Project Cardinal is designed to impact the early detection, monitoring and early treatment of cardiovascular disease across London, making optimal use of the secure data environment. We start with the late detection of heart disease, typically heart failure, weakened heart pump, atrial fibrillation, the most common form of irregular heartbeat, and valvular heart disease, which affects millions of patients worldwide. All three of these conditions are often detected late, after the patient has presented to A&E as an emergency. What we've demonstrated over the past 5 years, with work across Northwest London and beyond, is that implementing innovative technologies in real-world clinical pathways, such as an artificial intelligence-enabled stethoscope, together with clinical guidelines, data governance, regulatory approvals, can improve the early detection of these conditions in primary care in the hands of general practitioners, resulting in not only earlier diagnosis, but earlier treatment for patients. The second component is downstream of that part. Someone's been diagnosed with severe valve disease. They need a valve replacement. Unfortunately, in the NHS, many patients are dying while on waiting lists for cardiac procedures. What we've implemented in Northwest London and supported with the implementation across the capital is a system of monitoring and prioritisation of patients who are at highest risk. We've used some of the existing digital infrastructure in Northwest London, including the virtual hospital system, to enable patients to access a very simple app or to receive telephone-based monitoring so that they are kept safe while they wait for their surgical procedure.
Along that spectrum of early detection and mitigation of risk on waiting lists, we're also looking to leverage the SDE for much better early prediction of risk factors of cardiac disease. So that includes high blood pressure, lipids, which traditionally have suffered pilot after pilot for trying to pick up patients sooner and get them onto management and treatment. With this population view enabled by the SDE, we can create a true learning health system that applies prediction models that picks up patients who are at risk of undetected disease but also suffer from health inequalities and aren't picked up by the traditional routes. The important thing about the Cardinal project is that it uses the SDE to underpin delivery of clinical care for these patients, and we have a variety of innovative, data-driven, digital health technology-enabled pathways to pick up more cardiovascular disease in these health inequality-enriched populations. Cardinal is a blueprint for impact, not just in London, but in other geographies in the UK that will start to apply their SDEs for population impact. I think the beauty of the Cardinal project is that it converges a whole group of stakeholders who share one mission, and that is to deliver impact for patients. So we have local authorities, the Greater London Authority, NHS providers across all of the different ICSs, and importantly the SDE partners in North East London at Queen Mary and the AI Centre in South London, all underpinned by a wide participation from patient groups with lived experience of cardiovascular disease.
The proven impact across Northwest London is in direct clinical care and has off-ramped into sustained implementation for early detection and treatment of cardiovascular disease. We've seen in the TRICORDER programme in Northwest London a 2- to 3-fold increase in early detection of heart failure, atrial fibrillation and valvular heart disease in primary care. We expect that impact to be translated across the capital through the Cardinal programme.